should start again really, because that hasn't recorded at the beginning. Such a nice intro as well, just wasted. I should say the stat for anxiety. So morning everyone. Kate, such an impressive charity. Okay, so laughing to one side. Basically, there is a significant problem getting help for emotional concerns. And I want to divide this short talk into 3 areas. The first area is to really look at the problems, why things are going wrong, why are there these delays, if you like. The second area is to give you some tips and pointers as to what I think helps when you're coping with a difficult situation. Now, my job, bear in mind, is dealing with any cancer that comes through Leicester Royal Infirmary. So that includes brain tumours, bowel cancers, breast, anything really. But Audrey will know, because Audrey used to work in Leicester, clinical nurse specialist who's doing a talk this afternoon. Audrey will know that we were trying to make a special link with the brain tumour team in Leicester, and we're still trying to do that, because in my opinion, you guys are facing more than the average amount of burden from your condition. So clinicians like me should be stepping up and saying, well, what can we do to help? You know, not only mapping the problems, which I'll show you in a second, but also saying what innovations can we use clinically. And at the end of this talk, I said there were 3 components. The third component is actually to show you some innovative examples of patient stories that are real, genuine, honest accounts that we collect, and I'll tell you why we collect them. We collect those patient stories, 1, to give that person an outlet to say what's happening, 2, to have as a legacy for themselves. If they want to do that, they can record their account as a legacy. That's recommended in the US guidelines, by the way. But 3, and this perhaps is one of the most important things, to actually show other people who are newly diagnosed how a patient has coped when they've already faced certain barriers. You know, they've already faced similar problems to you guys with fatigue or memory problems or concentration problems, but they've managed to find a solution perhaps. What we've done then is recorded their story, and then we show that story to new patients, either on the internet now, which is done as a private link, or on DVD. I recognise not everyone has internet access, so it can be recorded onto DVD and you can take that home and watch it. And we did invite people last time in Birmingham, and I put that invite to you guys as well. If anybody's interested in that programme, either as a participant, because we're still collecting narratives until the end of this year. And by the way, we've collected 50 accounts so far, and we're still collecting at the end of this year, because the bigger the database, the more influential, if you like, the account, the more matched it is to the new person who's coming along. So if anybody's interested in participating or receiving some, we're actually going into an evaluation arm. Heather, who's helping with the video today, is going to help us with the evaluation, which basically means rating the accounts we've already got to see how successful they are. However, I'm getting ahead of myself, because that's something I'm going to show you at the end. I'm going to show you an actual clip, and we may have 1 or 2 mini clips along the way. But what I want to tell you at the start is that, in my opinion, I don't know if you agree with me, because you've been through the medical system quite a lot recently, but I think medicine, the medical model, is changing somewhat. You know, in the 70s, the 80s, we had this kind of authoritarian medical model where the doctor was in charge and they would decide whether you needed to know about your condition. In fact, the statistics from the 1970s said that in 90% of cases, the doctor would not tell the patient themselves their diagnosis. They would actually withhold the diagnosis. They would tell the relative, oh, I'm really sorry, your husband has condition X, or your wife has condition X, but they wouldn't actually tell the patient themselves. And why did they used to do that in the 1970s? Well, the reason was because they thought it was kind of their condition to do what they wanted with. And in addition, they didn't want to upset people by giving the diagnosis. Now, 30 or 40 years later, things are moving on. And we realize, yes, it's never pleasant to hear that horrible diagnosis at the point that you're told in the clinic. But what really counts is what's somebody going to do for you with that diagnosis? How are they going to help you with it? How are they going to get you back into a life that is worth living? Basically, how are they going to support you with that diagnosis? And that is essentially what this talk is about. What comes next? We recognise the diagnosis is difficult, but what can we do to support people? Now, what they also used to do, by perhaps not involving people as much, is kind of put them into the sick role, which is another way of saying that you kind of have a lack of control, that you're defined by your condition rather than by things that you can do. And it's never good to be defined by your condition. In the worst case examples, you had these old school medical ward rounds through the kind of Nightingale wards, which all the beds down the ward. And the doctor would say, here's a chap who has, bowel cancer. But they wouldn't refer to them by name. The patient would be known by their condition, which is wrong. We recognise that as wrong now. They also would tend to wait for the patient to raise a problem if there was a complication or concern. And in addition, we had a much more physically based driven medicine. So holistic care or psychological and emotional aspects were somewhat ignored. And I'll show you some stats on that. But I think over the last 10 or so years, we're going towards a more interactive model in medicine, where we think, well, oh yeah, I'm the doctor treating this person, but it's not really my condition as the doctor. The person, it's the person's condition, and they are basically at the top of the hierarchy. So we should be asking them from the start, what do you want to know about your condition? Rather than talking about people in the third person to their relatives, ask the person up front, what do you want to know? Are you one of those people that wants to know all information? Do you want me to go to the literature and find you relevant papers, as some of my patients say? Some of my patients are not satisfied with expert advice. They say, I want you to prove it. Which I think is actually quite refreshing these days, to actually say, show me the very latest from the literature. Yeah, now I know that's not everyone who wants all that detailed information, but the point is that we can be flexible. We can tell people a minimum amount if you prefer to say, and you can still say this, I prefer you to get on with it. Just get on with it and do what you think is best for me. That's still going to get you reasonable care. But being a little bit more proactive, asking for help and for the clinician to look out for problems, that is perhaps going to reduce the number of complications that come up. And that also opens an option for a preventative approach where we actually put in place certain things. And it could be something really simple. For example, a good support network, which ideally you have with family and friends, but let's say that is an issue, that we supplement by the use of volunteers or group support in the hospital. Those kind of things can actually prevent anxiety, depression, and other complications getting out of control. And we've started, Heather and I, a group support program locally in Leicester, which is just about to run weekly. At the moment it's twice a month, but we're going to open it up to weekly very soon. And the groups are going to include a group for caregivers and families, which is another area I think we haven't really attended to as much as we should. And so more and more we're looking at holistic care, and rather than isolating the individual, promote their autonomy. Basically asking, what can you do? I know you've got this diagnosis, but what can you still do despite your condition? If you feel held back, how can I help you do more? That is the key question for people in my position at the current time. So let's start with some slightly bad news about whether issues are picked up. And this is mentioned to me by other colleagues as well, and I want to show you some stats on this. This is a pretty horrendous graph, but it simplifies into something really simple. Now, I'm talking about emotional concerns, and others are talking about physical concerns and other types of concerns. But what I want really is a parity on the emotional side, such that clinicians look for the emotional and social and psychological complications as much as they look for physical. So this is a recent study done by a colleague of mine in Florida called Paul Jacobson. And what he did was quite clever. He audited the notes of patients who had various types of cancers in Florida across each Florida cancer center. So each of these bars is a different hospital. And what he did is he compared quality of care, let's just call it receipt of care, who was treated for depression, who was treated for pain, across multiple domains. And I've summarized two domains, depression and pain, on these bars. And essentially what they show is that in the lower bar, that is the number of times in that hospital depression was attended to on a per patient basis. And across all the data there, it shows that patients were attended to on 50% of occasions for their depression. Attended to, not that they thought their care was great, it's just somebody said they're prepared to address it. Whereas in pain, it was addressed in 80%, on 80% of occasions. There's an immediate disparity. Now you will notice if you've got sharp eyes, one or two of the centres were equal. For example, Centre A had good quality care in both domains, but Centre H had poor quality in both domains. So individual factors do come into play regarding the provision of care that is actually available. And you will probably notice this yourself. When you compare notes together, you know, patient A may have got treatment for, let's say, a complication regarding their memory, but another patient, patient B in another centre, hasn't been offered that, but is having similar problems. We have these inequalities or differences now, and we've got to fight to reduce them, both on a hospital level and on a national and international level. And this is a demonstration. Now, I just said to you that this was the number of times that the clinician basically responded. Even more powerful is how many times the patient was satisfied. Now, there's a great study that's just come out. I'm sorry, it's another complicated bar chart, but it's from Johansen in Denmark. And they did the same thing, but they asked, how common is this problem? How often was it attended to? And key, how often was the patient satisfied by their care? And what I've done is I've ranked the latter. How often were they satisfied by their care in each of these domains? So at this end of the graph, patients were most satisfied. But not all patients were satisfied, but it was the most satisfied of any problem. And at this end of the graph, the patients were least satisfied with the care they were offered. And I'd like to read you the list, because at the top end, we've got 4 classical medical problems. And it's not a coincidence, in my opinion, that 4 classical medical or physical problems were mostly attended to. And they were pain, nausea, shortness of breath. Remember, this is a miscellaneous cancer group. And poor appetite. Those were attended to with some degree of frequency, certainly more than a third of patients. But at the most, patients were only satisfied with the hallmark symptom of pain on 50% of occasions. Although clinicians were trying to attend to the problem, like I showed you on the previous slide, on 80%, patients were only satisfied with their care on 50%. Now that is a red flag for anyone. That basically says that not on every occasion where the clinician tries to help is the patient really helped and resolved from their point of view. Yes, sir?
According to that graph, they at least did get help.
Yes.
Which is not what happens in a lot of our hospitals.
Correct. So it's very variable, isn't it? So at this extreme end, patients got help on 80% of occasions if they had a problem with pain. But let's say a patient had a problem with their family or concentration or sexuality. Well, let's take concentration. In terms of concentration, if you look at the graph, nearly 40% of patients said, I've got this problem. But they were only helped on about 26 or 7% of occasions. 26 or 7. Roughly 1 in 4 helped. 3 out of 4 not helped. How many were satisfied with the help that they received? Unfortunately, only 10%. Only 10% were satisfied with their care. That presumably resolved or went a long way to resolving the situation for concentration. So let me read you the list of things that were classically not helped to a high degree. Problems with sexuality, problems with concentration, problems with relationships, anxiety, fatigue, function, daily function or physical activities, work activities, and depression. And that's not an exhaustive list. They were just the things that they surveyed in that particular study. So these are red flags to say, you know, we've got to do some work to helping with that. And by the way, that was the slide, the proof, if you like, that the delay to getting help for depression that I mentioned in the intro was 8 years. The study from Philip Wang in the US, 10,000 patients approximately interviewed. How long was it from your first symptom of depression until you got help? Well, this is the number of people getting help, and that's the 50% help rate. That's 90% help rate. So if it took 8 years exactly for patients to go above 50% helped for that condition. And it was longer, by the way, for anxiety, and longer for alcohol problems, and longer for memory and concentration problems. Although that is poorly studied, I have to say. Delay to getting help for memory and concentration. Now, why is it these things are taking so long to get helped, and why is it that we've got poor care? Any suggestions? Why is there this variability across all different centres?
I had my brain operation in 52, and around about 1960 or thereabouts, no, just before, I was still at school, about 1957, I was given diazepam.
Yes.
Recently I've read about a study about it that says it was it's linked to Alzheimer's.
Well.
And back then I was finding it very difficult to remember what we had done the previous day at school.
Yes.
Because the teacher would say, when I went to school, now let's start from where we left off. And I'd completely forgotten. I'd have to say, so where did we leave off?
Can I give you an answer to the link with cognitive impairment? First of all, there is a link between a high dose of a benzodiazepine and a current cognitive impairment. At an extreme, if I give somebody a very, very high dose, you'll be tired, very, very tired, and then asleep. And then if I try and measure your memory and concentration, it will be increasingly poor. So there is a link, but what you're flagging is a paper that suggested that there would be a statistical link later on, an epidemiological link years later. Now, in my view, there isn't a link between current diazepam use and later dementia, but let's say in the way you're thinking about it, which is that it's doing something bad to your brain and then later you're predisposed to getting a dementia. It's more likely to work like this, that if somebody did have a substantial and deteriorating cognition, and let's say in a year's time becomes diagnosed with a dementia, officially a dementia, then in that prodromal year, the doctor is trying to struggle, if you like, to work out what's going to help that person. And that person can present with secondary symptoms. Some people call those behavioural symptoms. I don't really like that term, but for example, they're getting agitated or depressed on occasions, or there's wandering if the dementia is severe. Now, those problems are often treated, not necessarily appropriately, but statistically by using one of these psychiatric drugs. And one of the common ones is a benzodiazepine. So what I'm saying in a very long-winded way is, you can have an artifact, it's called reverse causation, where the person actually has the condition and it's accumulating, and the drug is being prescribed, and then if you come along as a researcher, you find an association over a period of like 1 to 5 years, and it's easy to say, was that the cause? But the drug wasn't really the cause, it was that the condition was there. To prove that there was a cause, you'd have to take a healthy group, an entirely healthy group, give them the drug for a long period, monitor them all like in a cohort of 1,000 patients, ideally randomize with a group who didn't have the drug, and then see what happens. So there is a link, it's a link that is related to current cognitive impairment, because a high dose will cause that, and then this reverse causation model. But you are right to raise it. But does anybody have a view on why these inequalities in health exist in relation to mental health or psychological concerns? Why is it that things are not attended to, perhaps in the way we would like?
Is it because it's a new science?
Yes, it could be that. I mean, really, psychiatry as a profession has only been around about 150 years. If you look at neurology or internal medicine, they are 500 or 1,000 or longer years old. So yes, it's a relatively new profession. And another issue, I don't know if people would agree, is resources in this area are patchy. in my own service right now, we are facing a major cut to psycho-oncology in Leicester. My own employer said, to save money, we're going to delete your post entirely from the hospital. So we'll just rely on others to treat this, treat this problem. They've actually slightly reversed their decision, because the patient group said, no, we're totally against this. We value the input that this service is providing, and we really don't want to see this cut. So there is a question about resources. Now, I want to show you a clip from a chap, if it works, which will perhaps give you a hint why certain problems are missed. Because if you have a mental health condition, unfortunately, it does have an impact on your physical condition. And statistically, if you have a mental health condition, people are less likely to attend for their pre-cancer screening. They have actually lower rates by about 5%, it depends on the condition, of cancer diagnosis. So things are not picked up in time. And they have lower rates of cancer treatment. That means their chemotherapy or other treatments, surgery or radiotherapy, is not offered to them in a prompt way. Not in every case. There's a trend in that direction. There's significant. And there's a problem staying on treatment, and there may even be a higher mortality when a mental health problem is there. Now have a think, why do these problems exist? And I'm going to show you, if it works, a clip now from a chap who has a brain tumour. I showed this in Birmingham. Very nice guy who Audrey knows as well. And he's given permission for me to show this clip. And what he's going to tell you in this clip, amongst other things, is whether his tumour was diagnosed in relation to his suspicion of being depressed or anxious at the same time. So was the mental health condition interfering somehow with his care? Have a listen out for that. It's about halfway through this clip. And this is taken from the Cancer Stories programme I mentioned at the beginning. So that was Chris's quite powerful account. That was a snippet from his full story. I haven't got time now, obviously, to show you the full account, but is anybody interested? Hands up those interested in the full account at a later time. Basically, what I'd ask you to do is give your details to Heather or email me directly.
Two questions.
Yes, please.
First of all, have you ever given this talk to UHL board?
No. In fact, we are waiting to be invited by the CCGs to take an interest in our service because of this current cut, and in fact a threat of cut. On this Friday there is a meeting with the CCGs to discuss whether we're going to keep the funding for this year basically, or whether it's going to be lost. So part of that is to talk about the good work we're doing. But we have to be invited by them, and we haven't been invited yet. But what they have done is invited patient representatives, which I think is quite good, because in some ways the patient representatives who we've already treated, as Heather knows, give a very powerful account themselves, including Chris and others. So it's quite a pertinent question. Thanks for asking that. The email's in the bottom corner there, if you can read it. ajm80@le.
A member of the public
To
UHL board to ask that question.
Yes, although I'll just tell you, between you and I, my employer is LPT, although we give the service to UHL. The employer is actually the GP consortia. They're called CCG now, so they're the fund holders. I'm getting very political now. And my employer is LPT, which is a mental health trust. 30 patients have written in, and 3 MPs, to protect the service. So they have been trying along the lines that you're suggesting. And I'm very amenable to any talks that you suggest. And if you want to suggest any, if you have personal connections to invite me to present anything, I'm very happy with that. That's not a problem at all. So anything that you want to suggest, I am open to.
The second point is, it's not a question, but basically a year ago, almost to the day, she was taken out. She came out, she had a brain tumour, and then she got okay, and then everything went sky high.
Yes.
Light went down, everything. So in December, I went to the GP. I said, look at the writing. she's difficult to live with, blah, 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 blah. So he sent her, where did he send her? By ambulance to A&E. And so what did she do? She saw the same people at A&E she saw a year ago. And all they just did was up her drugs. The fact her handwriting had gone down, she had problems, the relationship, everything.
Yeah.
But basically, they just doubled drugs and sent her home again.
And
It's more or less what you said.
yeah.
Since then, obviously, we've had problems with that. We're sorting out. But the GP doesn't want to know. I mean, when you give someone's handwriting, which is going downhill, and everything. I mean, I'd get her clothes in the morning. She put them on at night. Have a bath and put them on again. And behaviour like that. It didn't ring a bell with the GP, so he sent her to A&E in an ambulance.
Yes.
I mean, it's ridiculous.
Can I say that from an organisational point of view, I would like to see your work in delayed diagnosis extending to adults. I don't know if you're working on, I'm sure Kate will tell us later, but I'd like to suggest that. But on a personal note, obviously I sympathise with that issue, and it is similar to some of the citations I've given you. What I'd like to say to the audience here is I'm not actually trying to rubbish the medical profession or GPs. I recognise they have a difficult job, and their hands are often tied by relatively short appointments, statistically about 12 minutes. And often patients with brain tumours who are not diagnosed but coming to medical attention present with complex symptoms that the GP wouldn't necessarily say, aha, I know what that is. You know, it's not such a classic symptom often that they know what to do with. For example, if you look at the classic symptoms, they're on my slides in the next few slides, but they're complicated graphs, but I'm just going to cut to the list. So when we looked in 500 Leicester patients, and it's been done in the US as well, the common symptoms that people have post-diagnosis, I have to say, are worry, anxiety was the number one we found, fatigue and energy problems, depression related to anxiety, family or relationship problems, memory and concentration problems, and feeling alone, feeling helpless, or not knowing what to do. I mean, that statistically was the list that we found, although there's a much more extensive list.
Forgive me, we're still talking about pre-operative here.
No, this is post-diagnosis. Post-diagnosis.
Post-diagnosis or post-operative?
Both post-treatment and post-diagnosis. So they all had the diagnosis, and the vast majority, had received treatment. Now, when you present with, let's say, slightly grey, let's take fatigue. Fatigue is a good example. Now, whose job is it in the hospital to attend to fatigue? It's actually a kind of a head scratcher, because it's not really anyone's stroke, it's everyone's. Do you know what I mean? It's actually not, there isn't generally a fatigue specialist. There may be actually a branch of rheumatology that looks after fatigue. There may be a group of endocrinologists that look after fatigue in some situations. There may be sleep specialists that take on fatigue as well. Psychiatrists may take an interest in fatigue. But everybody's looking for fatigue related to their core diagnosis. But when you come with the symptom, the core diagnosis is not necessarily clear. That's the thing in question, isn't it? You've got a symptom which is a flag, and you want that to be followed up in a prompt way. So what I want to do just there is to acknowledge that it can be tricky. What you really want is to work with somebody you trust in achieving a prompt and timely diagnosis where it's possible, with prompt and timely investigations. In fact, that raises in my mind the question about getting help. How do we get help, and who helps us? So I want to just skip ahead a few slides and go, because time is short. I'm going to talk about getting help now. Now, what we did here is we surveyed a group of 401 chemotherapy patients who were attending the chemotherapy for miscellaneous cancers. And what we asked those patients is, in general terms, what kind of help do you want right now? And in general terms, who do you want to see? And obviously, I'm asking them from a mental health specialist point of view, but I was addressing the question very broadly, so I wasn't restricting it to one particular domain. I was just interested in what they'd say, but they probably answered a lot to do with emotional concerns. Is that fair? Because of who was asking the question. So let's look at what they said. So this is what was most popular and least popular, and this is Leicester data based on who wanted help and what help is wanted. Basically, to help support them and look at their problems, what they said, number one choice was a trusted clinical frontline colleague. Ideally, that would actually be the clinical nurse specialist. And the reason I cite clinical nurse specialist is the clinical nurse specialist is usually expert in the area. They usually have a little bit more time than the medic, the oncologist, or the other allied health professional will give you. And they often form a very good rapport with you, so that basically trust is high. Trust is often high. So that person, the frontline clinical nurse specialist, was the number one preferred person. That's in the next slide. Who? What else did people want? Well, the second most popular request was complementary treatments, which generally we don't offer. I mean, generally we're quite hopeless in the NHS offering complementary treatments. In fact, we're not even sure whether we should, because we're always debating, is it evidence-based? You know, does it improve outcomes? Well, generally it does improve well-being at the time, and isn't that sufficient to say, well, we should perhaps be offering it? And the number of times I have to give people links to where to go, but at cost. And I just know they're not going to be able to follow those through. About half wanted information, although our information is often rated as quite poor. That is a key issue. You know, information, just mountains of information on its own, is actually not that useful. Whereas guided patient-rated information, that is useful. And I'll show you an example of that in about 1 minute's time. Some wanted group therapy, and at the time of doing this slide, we didn't offer group, but you heard me say, Heather and I have started that now, so we can actually say hand on heart, we have listened, and we are trying to attend to that. Some wanted some self-help material, which I think is a big issue. What happens when you go away from the hospital? In fact, if you look at time related to anxiety or depression, one of the most anxiety-provoking times is paradoxical from a medical point of view. It's when you're transferred from acute care into monitoring. Because in the monitoring phase, often it's periodic, let's say every 6 months, you know, you're apparently doing well, things are stable, you know, that's potentially some good news for you, but the medics don't say, oh, we need to keep a close eye on you every few weeks. But you've been used to getting a lot of medical attention from the wards, a lot of scrutiny, which of course has been not ideal, because nobody wants to be on the ward all the time, but by the same token, it is somewhat reassuring to have that contact. And then when you're sent home with this routine monitoring, it can be very anxiety provoking. So home help and self-help, which can be done at any time, can be very powerful, and we really need to develop these more in the medical profession. And the least popular in our list anyway was the classic medications that this chap raised, that we perhaps are sometimes too quick to suggest. And you heard me say this, who did they want help from? The clinical nurse specialist was most favoured. Family and friends, they said they still wanted help from. Somebody to give religious or spiritual advice, and least popular was me, you know, the psychiatrist. Very, very unpopular character in the hospital, I have to say. Whoever wants to see a psychiatrist, you know. So there are problems, though, that, joking aside, it comes down to this, that there are problems getting timely help. Sometimes it's because we don't request it. And I would put out the appeal to the audience that you should be thinking of yourself as, you know, am I managing okay? Is it worth asking about these problems? Don't be shy or afraid to raise them with your team. Sometimes help is not available. Sometimes, however, help is not given. And very occasionally the wrong help is given when help is given. And statistically, help is not given. Am I serious? Help is asked for and it's not given. Well, we've just done a meta-analysis, which basically means a look at all the data on this topic of whether help is given. And when the patient presented to their clinician, forget the graph, just listen to what I'm saying. When the that's what I usually do. I present a completely incomprehensible slide and then just tell you the message. It's just for me, actually, to remind me what I did. So when we looked at this data, when the patients went to seek help from their clinician at multiple centres, only 4 out of 10 times across all problems did the clinician attend to that problem for a mental health or psychological or an emotional concern. And that's in press in one of the journals. So I want to come on, I've got 2 bits to do, which I would be really remiss if I didn't cover, because I've actually covered a lot of problem areas, but I want to talk about some ways forward. So these are some of my tips. I just actually wrote these last night. I thought would be helpful. And these are the kind of themes that come up in my clinic from time to time, quite regularly with patients, almost regardless of their condition, but assuming they're struggling right now and there's a problem. So I just cited one, which is please ask for help when you want it. And I'm sure you'll try and take that on board as much as you can. The other thing is I've been impressed with the power of peer support from our support groups. We've only been running them about 6 months, but it's surprising how much help they give. Now, we do have the situation occasionally where patients are nervous to come to a group format because, what is going to be discussed? Do they have to tell their life story? What are they going to ask? But every time, patients have actually found that of benefit, even when they've been nervous. But to help the patient even more, Heather and I thought, well, we've got 2 or 3 patients that say, I'd like to come, but they never come. They actually can't get over that anxiety of, what's going to happen? So what we did with the other patient's permission, we recorded a session of group therapy, and then we give that link to a prospective new patient, and it helps desensitize them to the idea of what's going to happen. And they actually sometimes can even recognize familiar faces when they come, and it helps with the attendance at group. Now, number 3 is quite key. It was in another video. I'm not going to have time to show you that clip, but the attitude is key here. Now, we know for a fact that when you've got a troubling diagnosis, you lose things that you previously were proud of. For example, sometimes your employment, sometimes your relationships, sometimes links with friends that aren't keeping up with you in the same way. Sometimes it's more personal, your confidence, your abilities. It's tempting, it's very tempting, and it's automatic to say, what have I lost? What can't I do? Is it worth really getting up today, given what I've lost? It's a very, very natural perspective. Almost the more you were doing before, the more the problem is manifest to you at that point. But invariably, the patients that are doing well, even if they've come from that starting position, take the view that, yeah, I'll acknowledge I've lost those things, and they are problems, and I wish I could get them back. But I'm going to strive to do as much as I can. One, I'm going to try and get back some of that function. So they'll aim to get back the function. They won't just wait for the day that they feel better and then go out. They'll actually try and venture out, even though it might require an awful lot of bravery to go out when you feel your self-esteem or confidence has changed. But they'll also do something else. They'll say, what new thing can I do? What new thing can I do which I perhaps didn't think of before, but is within my capabilities? Even if it's a small thing, a little interest, a little hobby that will give me something to say, you know what, I've still got a role. I've still got a role in life, and I'm not just defined by my condition. And that is a powerful thing that people say, and it's about looking at what can I do? And what can I do? That kind of attitude. And I know it's easy for me to say it, but I'm recounting to you that patients are doing well often have made that transition in that kind of change of approach. And if you do try more and more activities, obviously, start slowly at a bottom line which is manageable, but try and build up gradually. Almost think of yourself as your own rehabilitation specialist. Once you're discharged from hospital, that is really the rehabilitation phase, where you're trying to concentrate on function, not so much on medical illness and disability. Use family and friends, use them to your advantage, use them therapeutically, use them to help your motivation, to get out as a prompt. Think of scheduling, where you schedule activities together, even small things. Try and spend some quality time together, so it's not all just about your illness, not just all about being unwell, not all about hospital visits. And plan for the future still. Plan for the future in terms of your direction in life still, even if it's a short-term plan. I would recommend people always have some small positive to look forward to. Something positive that's on the horizon. Maybe you're going to book a holiday and you're not going to be able to do it. But maybe thinking about planning for the holiday and planning for something small, maybe not a big holiday, maybe a small one, is something that can give you something positive to have in the background. Because those positive thoughts, they tend to offset negative thoughts, depression and anxiety. And if you can plan for those positives, it can be quite powerful in making life more balanced and worthwhile, if you like. Right, I'm going to now show you just 2 slides on the innovations, and then I'll show you a chap's story who, to me, is quite powerful in terms of that attitude. And Heather and I recorded this only last week. Now let me just show you the innovations first. So I've said a lot about what was wrong. I've said about my tips. I'm going to show you a few cases and what we're doing there. And I'll show you the program for the story. Now, some of the messages that I've said today are in this slide in terms of treatment. The ideal treatment is obviously effective, but it's also acceptable, easily accessible, perhaps available at home, and proven to work and value for money. Could it be that a simple intervention that was available systematically nationwide could be more powerful than a classic intervention like seeing me in the clinic? So the old medical model is seeing me in the clinic and, having a consultation. That's great, it works. But how many people realistically can see me in the clinic? Well, if they cut my post, sir, the answer will be none at all. But that to one side, could there be a treatment that is literally more than a medical consultation? And what I've learned from the group therapy is the power of peer support is quite powerful. So what we've done now in this story, which we call Cancer Stories, is put people's accounts into a video format, which is then inspirational in itself, but also out there. It's out there on the internet, so people can log in for free and get help online. And if you're really in the high-tech revolution, not Kate, by the way, but everybody else, you can actually get it on your phone, on your smartphone, and you download this as an app. So it'll be an app on Apple, iPad or iPhone. So the app will basically present you with the stories, and you can say, it's not up to me who you watch, it's up to you who you watch. You can choose to say, oh, I'll watch this chap, they look interesting. And in the beginning, they give a 2 to 3 minute synopsis of their life, don't they? Basically to say, this is me, this is where I'm coming from, this is my diagnosis. And then you can choose to listen to their whole account. And what we're working on now, over the next 6 months, is to break their accounts into relevant, helpful themes. Because although the full accounts are really very valuable, they're actually quite lengthy because I have to do justice to the person. So we give them 30 to 60 minutes to tell their account, which is effectively a DVD's length. But if you're watching quite a few stories, I know you're not going to watch like 10 one-hour accounts. So we're going to break them down into themes like fatigue or concentration or depression or anxiety. And then you can just watch 5-minute clip from, Chris on fatigue, let's say, and then that will give you a focus. What was helpful for him? So we're working on that right now. It's going to take us about a year. But right now we're in the evaluation phase behind the scenes, and that's why I said to you at the beginning, if anybody's interested, you can email me and you can be on the evaluation panel, which means we will send you a whole link of, let's say, a real example, a real person, with their permission, and you can tell us what you thought of their story and how we could improve it. And also, how therapeutic was it for you? And you never know, it might be of genuine benefit for you. So the last bit then, I'm going to show you the clip of Alfie, who actually doesn't have a brain tumour. He has a head and neck cancer. But a lot of his issues are similar. And his issues at this stage, he recounts a story about how difficult it was to go out of the house when he'd had his change of appearance and everything. And a lot of that is shared with a lot of people. So I just want to play his 5-minute clip, and then time will be up for me and we can have the long-awaited coffee break. So that's a touching story. There was Alf Banks, who has been a patient champion for our service, resisting the cuts incidentally. And he came in to see us over a year ago. He recorded his story, but we've improved.
There we go.
That's known as the time to finish signal. It literally is time to finish. So thanks for your attention, everyone, and let's just bear in mind we can ask for help, and let's try and put emotional concerns onto the map. Thank you very much.